Okay, thank you very much. Thank you all for attending. And I'd like to thank Milton especially for inviting me and for the home hospitality. So I'll be talking about expanded carrier screening. Every couple should know their risk. And this is particularly important for patients undergoing in vitro fertilization, but certainly applies to all patients. So basically, once the structure of the DNA has been found, we continuously detect more and more disease-causing mutations. So to start off, just to place us in the right direction, this is the way I explained it to my patients, how difficult it is to find the disease-causing mutation. So basically, the entire genome, we think of it as like an encyclopedia, where we inherit from our parents 2 copies of the same chromosome, where each chromosome is like a volume of the encyclopedia, and just like we have different chapters in the books, so we have different genes in each chromosome, and then just like the chapter in the book is written in words and letters, so is the sequence of the genome containing about 3 billion base pairs. So the genome is quite complex. We have about 20 or 23,000 genes, and finding a mutation is not like finding a needle in a haystack, but finding a needle in multiple haystacks. So it becomes difficult to find disease-causing genes. Why is it important to find a disease-causing gene? This is because monogenic disorders stemming from a mutation in only one gene account for about 80% of what we call rare diseases. And 50% of rare diseases afflict children, and 30% of these children will not reach the age of 5 years. So this is certainly an important disease burden. It's also important because now we have emerging treatments for some of the cases, but when we think of it from the reproductive genetics point of view, we would like to identify the couples at risk before they get pregnant, so that we could offer them genetic counselor. We can help them inform other family members who will be at risk of being carrier, and then discuss and offer certain reproductive options for prevention. So prenatal diagnosis is certainly a method of preventing. We can do it by either amniocentesis or CVS, but this is secondary prevention. That means the woman is already pregnant, and then we use certain techniques to detect if this baby has a disease-causing gene. But we can also have primary prevention. This is if we know that the couples are carriers before they get pregnant, we could offer them preimplantation genetic diagnosis and offer the transfer of genetically normal embryos. So how do we detect conditions? For the very rare mutations, for very rare disease, at least currently, we have to wait until a first family member is born with this condition. So currently, we cannot screen for all several thousand disease-causing genes. At least nobody is offering right now. So depending on the type of disease and so on, we could offer targeted mutation testing or just sequence a single gene. But now we have multiple gene panels that we can at the same time screen for many different conditions. We could offer whole exome sequencing or whole genome sequencing. And in fact, this is done more and more commonly for children with a genetic condition that we have not diagnosed. But there's certainly enough common, and when we say common, it's 1 in 1,000, 1 in several thousand, and so on. This is in genetics relatively common. So for the common diseases, we can offer population-based screening. That means we screen the parents before they get pregnant. So what should we screen for? Of course, as mentioned earlier, some of the conditions like color blindness are not really severe enough to merit intervention. But we can certainly, and it's important to screen for conditions causing intellectual disability, severe handicap, the need for surgical or medical intervention, and conditions that affect the quality and the length of life. And the conditions which prenatal diagnosis may achieve and lead to early intervention, thereby eliminating the disease, or optimize newborn outcome by specialized care. And then some parents will not opt for termination of pregnancy or any intervention, but would like to be educated and then make the choice where to deliver and so on. So the paradigm for population-based screening has begun, I would say, with Tay-Sachs screening. And this is a disease, autosomal recessive disease, common in Ashkenazi Jews, where 1 in 25 is a carrier, and causing psychomotor regression and early death. It's caused by a deficiency in an enzyme. Carriers have been known to have reduced enzyme activity. So carrier screening began even in the 1970s, and this was done by enzymatic testing, not by molecular techniques. And this has resulted in virtual eradication of the disease in the population that has been screened. So this is a typical characteristic autosomal recessive inheritance, where both parents are normal carriers. They don't have the condition, but each carries an abnormal gene, I would say non-working gene, and a working gene that saves them from having the condition. And then you have 75% of having a child which is healthy, either non-carrier or a carrier, but 1 in 5 of having affected condition. So based on this assumption, the paradigm, the early paradigm for ethnic-based stepwise screening has been to take the population and then choose just one partner, usually it's the woman, and then this population is screened for the condition that we look for, so be it Tay-Sachs, cystic fibrosis, and so on. And then we detect the ones who are carriers, the ones that have a star. We isolate the carriers, we invite in their partners, and we screen the partners as well. So only the couple where both are carriers will be offered prenatal diagnosis or preimplantation genetic diagnosis. So the first conditions that we can screen for, and they are pan-ethnic, so they are relevant to most populations around the globe, would be cystic fibrosis, spinal muscular atrophy, the thalassemias, and Fragile X syndrome. So cystic fibrosis is common worldwide. It has a frequency of about 1 in 2,500. So a carrier frequency, at least in the Caucasian population, is 1 in 25 to 1 in 30. And there are many, many different genes, but each ethnicity has a unique set of a unique set of mutations that are screened for in that particular population. And the disease causes several health problems, and it certainly is one of the most common and lethal conditions. Spinal muscular atrophy is the second most common autosomal recessive lethal condition, with a carrier frequency of about 1 in 40 to 1 in 50. It causes degeneration of lower motor neuron, leading to muscular atrophy. And the most severe type, which is more than 70% of the cases, result in early death. Now, a company called Biogen has developed a product now that's being tested around the world to cure these children, but that's not really cure, that's just prolonging the disease state. So screening for this condition is kind of difficult because normal individuals have 2 copies of the gene, carriers have only 1 copy of the gene, and affected individuals have no copy of the gene. However, some individuals have 2 copies of the gene on the same chromosome and a deletion on the other. So these are carriers, but quantification methods do not differentiate these carriers here that have 2 copies, albeit on the same chromosome, as opposed to these individuals have 2 copies, but 1 on each. So screening is not perfect, but yet it achieves a high degree of detection, and the residual risk for a screened couple will only be about 1 in 2,000. Thalassemias are common worldwide, and they could be both alpha thalassemia and beta thalassemia. This is the hemoglobin molecule consisting of an alpha chain, 2 alpha chains, 2 beta chain. For the beta globin genes, we have only 1 copy on each chromosome, And for the alpha globin gene, it's more complicated because we have 2 copies of the gene on each chromosome, a total of 4 as opposed to a total of 2. So for beta thalassemia is just a standard autosomal recessive condition where 1 in 4 is affected, 2 out of 4 are carriers, and 1 out of 4 is a healthy non-carrier. And screening for this condition could be achieved relatively easily by just red blood cell indices, where normal individuals have MCVs of about 88, 89, and mean corpuscular hemoglobin about 30. But carriers have lower indices, and affected individuals have a much lower red blood cell indices. And diagnosis can also be more refined by using hemoglobin electrophoresis, measuring the different types of hemoglobin. This is standard screening, but of course now using molecular techniques we can screen for many different disease-causing mutation without the need for going in the stepwise manner and just checking the entire spectrum of disease-causing mutation or even sequencing the entire genes. So in beta thalassemia, most of the disease-causing mutations are point mutations. But each population has a different set of these mutations. So it's important to note that if you screen for mutations, you have to either adapt it to a particular population or else screen the entire gene. Alpha thalassemia is more complicated by the virtue of the fact that each individual has 4 genes instead of 2 for the beta thalassemia. So there are many different types of thalassemia, beginning from a silent carrier who has only 1 abnormal copy, or then individuals that have 2 abnormal copy that causes thalassemia trait, and individuals have 3 abnormal copies that will result in alpha thalassemia. And of course, if you have 4 abnormal copies, that causes hydrops fetalis and is lethal. So again, you could screen using different red blood cell indices and using electrophoresis, but then you can use molecular testing and use either sequencing or else detection of deletions, because in alpha thalassemia as opposed to beta thalassemia, most individuals, about 90%, will not have a point mutation, but rather a large gene deletion, and that makes it quite easy to detect using molecular techniques. The last of the pan-ethnic conditions would be Fragile X syndrome. It's one of the most common causes of intellectual disabilities, affecting 1 in 4,000 to 1 in 7,000 females. Carrier rate is about 250, and I know that it is less common in Southeast Asia, but still is present. And it is characterized by developmental delay, hyperactivity, and autistic behavior, and some characteristic facial features like large ears, a protruding chin, and so on. So the genetics of this is different. It's not an autosomal recessive, but actually it's a dynamic mutation caused by a triplet repeat nucleotide expansions, where in the 5' untranslated region of the gene, there is a triplet that occurs several times. So normal individuals will have between 5 and 55 repeats of that CGG triplet. Carriers of a premutation have between 55 and 200 repeats, and affected individuals have more than 200 repeats. So now that we try to screen for conditions like this, we could, and we have done this for a long time, we have screened by ethnicity. So for each population, we found the most common conditions and offered these populations the short list of genes and disease-causing mutations that is characteristic of that population. And initially, it's been quite straightforward. We could tell for each individual what their ethnicity was. They could tell themselves, so reporting was quite accurate. And you would ask individuals, you usually, in the past, you would find quite easily their background. But now with a lot of influx and moving populations worldwide, this becomes more and more difficult. So, for instance, in Israel, we used to screen for these conditions, Fragile X and CF, SMA, thalassemia, and so on. So we could tell which population to offer which disease to. But now it becomes more complicated because individuals now have different ethnic backgrounds. So either they know it, but it's complicated, or else they don't even know what their background is. Moreover, we've started detecting more and more disease-causing genes. So, for instance, in our population in Israel, we screened for more and more conditions, and it becomes almost impossible to remember which condition to offer which ethnic background. So, in the end, this becomes too burdensome and too complicated, and then we make mistakes because we either forget to order a specific test, or else we offer the wrong test for the wrong ethnicity because it was not reported. So this creates a paradigm shift. And that has been going on over the last years, but new technologies have enabled this to actually take place. So the paradigm shift is moving away from specific mutation for specific population, but rather offering an expanded screening paradigm. That means that all individuals, regardless of their ethnicity, are offered screening for the same set of conditions. And of course, these have to be wide enough to cover a different ethnicity worldwide if you want the test to be not universal, but at least make it effective enough. And then, as opposed to the past, where we used to counsel each patient about each condition being tested, which was mandated by common practice, now it becomes irrelevant. So you cannot counsel patients for hundreds of different conditions. It's enough to say that we counsel the patients generally, so it's not genetic counseling, but it's rather generic counseling. We explain that we screen for conditions that are severe enough, and then these conditions are included. Then again, it becomes difficult to counsel patients personally because we offer this now for all patients. So we now must resort to other technologies for conveying the messages using pamphlets, videos, online resources. So our patients are well educated and more use the online resources. So these could be harnessed in this way. And then the pretest consent, because you need to consent patients, will need to describe in sort of general details not each disease, specific disease, but rather the groups of diseases and their severity. So in some cases, the patients can decide to accept certain groups of diseases and not other groups, and so on. So there are different approaches to offering this type of expanded screening. One of them is offering a target mutation panel. So these are well-described, well-curated mutations that we know have caused the disease, and we know of them. So that makes screening rather easy because we know what we're looking for, and each of one of these disease mutations has been curated. And it's easier to counsel the patients. What this would mean missing rare mutations. So every time you do this type of analysis, you know that you will be missing mutations that are rare in this population. And for instance, if one of the partners is a carrier and the other partner undergoes targeted mutation analysis, there's always the chance that the other partner carries a mutation that is rare or has just not been included in this panel. So you will have to devise different panels for each population because that would have to depend on the types of mutation for that population. The other approach is using next generation sequencing, where you sequence the entire gene of interest. So it's more comprehensive. It would fit all ethnic groups because you will detect all mutations, both common ones, rare ones, and even ones that have never been described. However, that would result in finding variants of unknown significance, so we call them VUS. And this may be either difficult to curate because sometimes we don't really know. Using predictive algorithms is not really good in some of these cases, and may be more difficult to counsel, and is currently more expensive. But with the ongoing developments in the fields of NGS, we envision that in the future it will be actually cheaper than using other technologies. There's also the question of how do you do the screening? Do you do the screening in the same manner that we used to do before? Meaning screen one of the partners, and then only if that partner is found to be a carrier, we screen the other partner. So this is called the stepwise. So stepwise will take longer, and especially when you go on to screen for multiple conditions, 1 in 2 or 1 in 3 individuals will be found to carry something. We all carry tens or hundreds of mutations. So the more you screen for, the more likely you are that the first partner would be a carrier. Then it will take longer to counsel and then get the other partner in and check the other partner. So this will probably be better for couples who are not pregnant and have the time, and time constraint is not an issue. But more and more, it makes sense to screen at the same time both partners, because, as I said, 1 in 2 and 1 in 3 will need the partner to be tested anyway. So why do it in a kind of a lengthy manner? The only reason is cost. But as cost comes down, it may make more sense to test both partners at the same time. It shortens the waiting time, certainly preferred during pregnancy. And then if you offer next generation screening panels where you sequence the entire gene, it actually makes more sense, because if both partners don't carry any mutation, that's not a problem. That's great. If then one partner carries a mutation in one of the genes, the other partner has already been screened for, and also if that partner has been screened by next generation sequencing, then you've finished everything. You're done, because you've searched for the common but also for the rare mutations. And if both partners carry a mutation in the same gene, then you go ahead with doing prenatal or preimplantation genetic diagnosis. So it makes the paradigm, it makes the process simpler and easier. And then counseling can be done only once you get the results. Normal, one is a carrier, the other one is definitely not a carrier, or both are carriers. So here are some examples. These are from companies. Counsel is checking for 218 genes. Mount Sinai, and next step now is called Semaphore, checks for 281 genes. Baylor College test called GeneAware tests for 158 genes. And then iGenomics tests for 549 genes, if I'm not mistaken. So certainly there are companies out there that have taken the challenge and now offer this both for patients who plan on having pregnancy, certainly for patients undergoing IVF, and also for checking sperm or egg donors. And it makes sense to do this because, unlike a couple that needs to stay together regardless of who carries what, and then they go for preimplantation or diagnosis or prenatal diagnosis, when you have donors, they don't need to stay together. All you need to do is just change the donor, and then you're done with the problem. So certainly makes sense testing all donors. And these are some of the companies that offer these tests worldwide, and I'm sure there are some more. There's also this trend of a direct-to-consumer genetic testing, and I would like to point that out. This is a problem because this doesn't follow up with the same ability to provide counseling, and certainly the decisions made, the choice of conditions made, and the fact that the patients sometimes left with information that they find it hard to digest. So I know that there's some companies you even send for, you get a packet, you spit inside, and you send it back to them, and they give you the result. And I think the reason why we have these direct-to-consumer is because the medical community has been slow to adapt to this technology, therefore leaving a vacuum for these commercial companies to go into direct to consumer. So I think this is something that needs to be avoided. This is interesting because this has been a statement that has been made in 1975, and I'll read it to you. As new screening tests are devised, they should be carefully reviewed. If the experimental rate of discovery of new genetic characteristic means an accelerated rate of appearance of new screening tests, now is the time to develop the medical and social apparatus to accommodate what later on may otherwise turn out to be unmanageable growth. This is in 1975, so I know that this we have been slow to pick up on that. Now with new technologies, I think we should pick up the pace. So to finalize, expanded carrier screening enabled by next generation sequencing is the norm. 1 in 280 couples are at risk of having affected offspring if you use these screening programs. So overall, this is higher than the risk of a neural tube defect and higher than the risk of aneuploidy. So it makes total sense if you could offer expanded carrier screening for all. And then if you use expanded carrier screening based on next generation, they could be offered to all ethnicities, and it's simplified by simultaneous couple screening. And with this, I end. Thank you.